Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our Healthcare Regulatory Compliance webinar series with a presentation on Consolidated Appropriations Act 2023, Impact on Healthcare Providers. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenters by typing a message into the question pane of the control panel. We will collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Martie Ross, Consulting Principal, and Kathy Reep, Consulting Senior Manager at PYA.
Thank you, Laura. Good morning, everyone from snowy Kansas City. Kathy, how's the weather in Orlando?
Going to be up to about 85 today and sunny. Sorry. It's going to rain tonight, but
anyway, we are pleased to join you for our first webinar of 2023. I know Lori Foley did the deep dive into MIPS and MACRA earlier this month, but this is our first chance to speak with you in 2023. As always, if you look in the panel, the handouts panel, there is a PDF of the presentation if you want to follow along. And as Laura mentioned, of course, we always send out the recording and a copy of the slides to you following the webinar. But today's topic is the Consolidated Appropriations Act of 2023, which has earned its nickname CAA 23. Which I like a lot better than some of the other names we've had over the years. But this bill went fast. The text of the bill was released on December 20th. It passed the House 2 days later. The following day went to the Senate.
Read.
I'm sorry?
You didn't mention when the bill text was read.
That would be last week, I think, is when I finally read all of it. So I don't know about
it. No.
Exactly. But the bill was signed into law December 29th, which of course avoided the government shutdown because the primary purpose of CA 223 was to fund the federal government. Back in the olden days, we used to have Congress work its way through 12 appropriation bills. And usually that work was completed before the end of September and the beginning of each new federal fiscal year. But somewhere along the way, we went into ongoing panic mode where appropriations became a single bill passed at the end of the year to avoid the specter of a government shutdown. And more recently, sort of beginning with the Consolidated Appropriations Act of 2021, this end of the year legislation has truly become the kitchen sink. It is everything you couldn't pass primarily because it requires 60 votes in the Senate to pass anything now. So this end of the year bill, because it's a have to do, need to do situation, we end up clumping into that legislation a lot of other topics beyond appropriation. So this bill, for example, includes the aid for the Ukraine war, a lot of supplemental appropriations for natural disaster relief, electoral reform, the prohibition on the use of TikTok on your government device, and also protecting whales and other animals as well. So there's a whole lot here, as you would expect. It's sort of the culmination of an entire year of legislative activity. What we care about in the healthcare world is Division FF, which are the health extenders, improving access to Medicare, Medicaid, and CHIP, and strengthening the Public Health Act of 2022. And you'll see that is comprised of 6 titles. Title 1 is actually a piece of legislation that passed the House last summer. Again, never made it through the Senate, and so ended up being mixed into this legislative mess. And it is focused on an incredible number of initiatives intended to address behavioral health, substance use disorder, and a number of initiatives that we will see now going into effect over the next year. The Title II is a piece of legislation actually introduced in the Senate last summer. It didn't go anywhere. It's the Prevent Pandemics Act, which is primarily sort of rearranging the deck chairs, shall we say, on the federal government response to potential pandemics, who has the authority to do what, for example. But the remaining titles are those with which we are familiar, how we're going to operate the Medicare and Medicaid program and other human services programs. So that's the legislation ahead of us. What we're going to talk about today, more specifically, are some key provisions that will impact us in the healthcare industry on an ongoing and daily basis, most of which are disaster avoidance, that how the budgetary process was working its way through was going to have some significant negative financial impacts on the industry. The good news is we've avoided them in the short term. The bad news is they didn't go away, and we will probably be dealing with these issues over the next 2 to 3 to 4 years. So with that, Kathy, tell us the good news about PAYGO.
Can I give you the bad news too?
No, of course.
All
Absolutely.
right. So PAYGO, which is essentially the abbreviation for the Statutory Pay-As-You-Go Act, PAYGO is much better, is what brought us this threat at the end of 2022 that as of January, we would be the potential of a 4% reduction in a non-exempt spending, which would include Medicare. Just like you have a current sequestration of 2%, there was this potential that it would go either up to 4 or to plus 4, meaning a 6% sequestration on your payments as of January 1. Thanks to the activity in Congress, we did not face this. The CAA 23 essentially has delayed those cuts a little bit. So here's what we're looking at from a delay perspective. Essentially, we are protected until 2025, which comes very quickly because that's the way the government works. There are some exemptions related to PAYGO that would not be subject to reductions in the future. But we've got an issue, and this is where we get into the bad news. We're protected right now, today, but we don't know what's going to happen later this year. And I say this because when we first got this whole sequestration issue, the initial 1%, 2% sequestration, that came about, Martie, if I'm not mistaken, around 2011, the Budget Control Act. And that was at a point in time that we were dealing with the federal debt ceiling and hitting that debt ceiling, not being able to come up to some good agreement in terms of how we were going to address overall spending. And therefore they said, let's just pay everybody a little bit less, and that way we can reduce spending. We are there again. We've got major disputes going on in our country right now within Congress and the administration related to the debt ceiling. Is there going to be a sit down and a discussion of what we're going to implement at, to avoid hitting, well, we've already hit the debt ceiling, but what are we going to do going forward? And so are they going to impose some other reductions on us? Reductions in our rates, modifications to the program like they did under the Balanced Budget Act or the Affordable Care Act? Or are we going to suddenly start looking at additional, let's make it easy, more sequestration? Martie, any comments on that?
I mean, the lesson here is this battle, this was a battle, but the war rages on. And it is all too easy for Congress to not balance the budget, but certainly meet its obligations on the backs of healthcare providers, given that Medicare payments is probably the largest single segment of the non-exempt spending. It's the lever that is easiest for them to pull. So I take very cold comfort in avoiding this 4% cut. If the best solution, at least for healthcare providers, would have been for Congress to go back and say the root cause of this problem, which was the American Rescue Plan. It was the only piece of COVID relief legislation that was not by its terms exempted from PAYGO. So, you know, Families First, CARES Act, all of those had much higher price tags associated with them. In enacting that legislation, Congress said, yeah, but we're going to make this exempt from PAYGO. So you don't have to have offsetting revenue increases or spending cuts to pay for that bill. It just simply added to the deficit, which of course then increased the rate at which we hit the debt ceiling. But that's not what Congress did at the end of the year. They just said, just like we did in 2022, where we kicked the can down a year. Now here in 2023 and CAA 23, Congress just kicked the can down, down the road 2 more years. The other thing they did, in case you weren't, go back to the OG sequestration of 2%. It was supposed to be long done by now, right, Kathy?
Absolutely.
But we kept, again, all through COVID, we delayed it and we pushed it off. And so where we had stood in 2022 is that we were going to extend that 2% now through 2031. Except in 2030 and 2031, it was going to be higher than 2%. NCAA 2.3, Congress said, now let's go ahead and kick it 6 months into 2032, but it will remain at the 2%. So that's where it stands now. I'm pretty excited because I'll be retired by the time that we reach the end of that sequestration, but I am sure my grandchildren may be retired by the time we get done with the sequestration from American Rescue Plan.
And that's very possible. One of the things that they would actually implement as a part of any legislation this year is let's just continue it to 2050. Oh, now we've paid for things.
Yeah. So
no, we haven't, but it would be a way to address the budget.
Yeah. So I guess the lesson here is that don't take a deep breath. This issue is very, very real. And we unfortunately are the lever that is the easiest to pull to solve this problem. And so we need to be defending the ground. Okay. Let's maybe a little better good news. We can try that. Hold on. Simple things like moving the slides really do challenge me, as we all know. There we go. The conversion factor and what Congress did here. You got to have a little background to appreciate fully what happened. When CMS published the 2023 Medicare Physician Fee Schedule final rule, it announced a 4.5% cut to the conversion factor, as compared to the 2022 conversion factor. 2 reasons for that. The first was that Congress back in 2022 had provided for a one-time 3% increase in the conversion factor. So to avoid last year's cut, Congress stepped in and said, no, we'll increase the conversion factor, we'll infuse the dollars so that the conversion factor can go up 3%, so that minimized the impact of the cut last year. That was a one-time appropriation. So at the starting gate, we knew there was going to be a 3% cut this year in 2023, the conversion factor. And then CMS did what CMS does in the Medicare Physician Fee Schedule. It revalued certain codes. It added new reimbursement under other codes. And so that would result in an increase in spending under the fee schedule of more than $20 million. And thus the budget neutrality provisions kick in. And the statute says if you have increases in the fee schedule by more than 20 million due to additional reimbursement or valuation or the like, then you have to offset that by reducing the conversion factor. And so that resulted in the conversion factor coming down 1.5%. I don't think it's fair to call that a cut. It's just a reallocation. It's CMS saying we're going to spend money here instead of there, and we pay for it across the board. So, but the result was, by those 2 factors, fee schedule's coming down 4.5%, which is a pretty massive reduction year to year. The solution in CAA 2.3 is a 2.5% increase in fee schedule spending. That means as you compare 2023 conversion factor to 2022, it's a 2% cut. And then Congress went ahead and also addressed 2024, providing for a 1.5% increase. So that means out of the starting gate, the 2024 conversion factor is going to be 3% less than the 2022 conversion factor. Keep in mind, however, budget neutrality did not go away. So in this upcoming cycle of rulemaking, as CMS identifies, again, reevaluating codes, adding new reimbursement, that could again kick in budget neutrality and also result in a cut in the fee schedule. So it's not automatic that it's going to be a 3% cut in 2024. It could be more depending on what CMS does in the fee schedule rule itself. And once again, this leaves us with the question, what happens in 2024? When will this all catch up with us? Because if you do the math, given all these actions Congress has taken, you're probably already staring at a 6% reduction for 2025. And where will things be politically at the end of 2024? Is it a similar situation to what we saw in 2020 with the change in administration? Is it going to be a similar situation to what we had at the end of 2022 with one house changing hands? And how does all that play out in the physician fee schedule? So again, kind of won the battle, certainly still still fighting the war. Next up, related topic on the Medicare physician fee schedule are changes that Congress made to the quality payment program. If you remember back in 2015, we had the Medicare Access and Chip Reauthorization Act, which we now refer to as MACRA. MACRA made substantial changes into the manner in which physician fee schedule operates, and that included the creation of the quality payment program. So the idea under the quality payment program is we're going to start paying for performance as opposed to just strictly reimbursing physicians based on volume. And there are two options under the QPP. The one with which most are familiar is the merit-based incentive payment system, MIPS. And that results in a Medicare physician fee schedule payment adjustment, both positive and negative, depending on that physician's performance across 4 categories of measures: quality, cost, performance improvement activities, and promoting interoperability, formerly known as meaningful use. And you all know that you report your data, CMS calculates a score, that results in a fee schedule adjustment. What has happened over time, unexpectedly to some degree, is the positive adjustments have been really, really small, in large part because of accommodations made to enhance, probably artificially, performance. And thus you had fewer people performing poorly, which would have resulted in negative adjustments. Because MIPS is budget neutral, you only have as much to reward people with as you do penalize others. So it's not really had that necessary intended effect of creating that significant incentive to improve performance. The other option under the QPP was a physician meeting the standard as a qualifying APM participant, APM alternative payment model. And the QPP set up definitions and criteria of what qualified as a qualifying alternative payment model, primarily tied to the degree of risk that the physician is assuming under that program. There's a pretty substantial incentive that was tied to being a qualifying APM participant. Primarily, you avoid having to report on MIPS, but instead you receive this automatic 5% bonus payment on your fee schedule Part B payments. It was always a 2-year drag. So if you participated in the APM in 2022, you then would see that positive adjustment to your payments in 2024. The timeline that was created in MACRA assumed it would take about a decade for all of this to create a new incentive structure. And thus, Congress, in its future vision, said by 2023, everyone will be already doing this stuff, and we no longer need to be providing that 5% bonus payment. So what if you were in an APM in 2022, you would see that bonus in 2025, but if you were an APM in 2023, no bonus in 2025. And that, of course, becomes problematic when we are still doing everything we can to move physicians into these alternative payment models, but now we're eliminating one of the primary incentives. So Congress steps in and says, okay, For 2025, we'll provide a 3.5% bonus, obviously a reduction from the 5% that had previously been in the statute. But that means if you are in a qualifying APM now in 2023, so such as the ACO REACH program, for example, for the enhanced track of the MSSP, for example, then you're going to realize that 3.5% bonus payment for your payments in 2025. There's still this gap because we don't know what happens for your participation in 2024. At this point, legislatively, it's still a zero. There's no bonus payment you'd realize in 2026. The statute does provide that starting in 2027 and thereafter, so again, if you're in an APM in 2025 and any year thereafter, you're going to enjoy about a 0.75% increase in the conversion factor, so your payments would be higher over time. So that's where we stand. It's good news, but it's still, again, it's this question of where is this going to go forward? You know, at the time when we implemented MACRA, we thought we had solved the problem of these constant year after year doc fix because of the sustainable growth rate formula that had previously driven payment under the fee schedule. But here we are, you know, 8 years later going, oh, same song, different day. And so we're going to have to figure out our solution here on these incentives to drive physicians forward in quality improvement and participation in alternative payment models. I think I talked too long on these topics and then the mouse goes to sleep. So let's talk about telehealth flexibilities. Actual, real live, good news from the CAA 2.3, although of course there's work to be done going forward. If you remember, back in March of 2022, Congress decided that it would extend the telehealth flexibilities, i.e. the expanded Medicare reimbursement for telehealth services for 151 days following the end of the public health emergency. And you see the check boxes on your screen here. Those are all the specific legislative extensions that were made in March of 2022 for, again, 151 days post the end of the public health emergency. What Congress did in CAA 2.3 was to, in fact, extend those even further now through December 31st, 2024. So assuming that, in fact, the PHE is going to end in April, no guarantees, I don't know what they're going to do, but that means you would have continued these public health, these Medicare telehealth reimbursement flexibilities probably through the end of the summer. But now instead, we will continue to enjoy those through the end of 2024. The problem we have is what they did in the legislation doesn't necessarily match up with what's actually happening in practice. Because even following the action Congress took in March, CMS stepped in through its rulemaking process and filled in the gaps and said, okay, here's what's going to happen during the 151 days post PHE, and then here's what happens after that 151 days. And we had a predictable kind of understanding of what the world looks like. But now we have an extension that goes to the end of 2024, and we really don't know what the world looks like because CMS needs to do some gap filling. Hopefully, CMS will not wait till the usual rulemaking process to address these matters because that leaves uncertainty. We don't like uncertainty. We're hoping that we'll see an interim final rule. So what are the issues we're concerned about? What we don't know, first and probably foremost, is that expanded list of telehealth services. Remember, pre-pandemic, we had about 100 services identified by CPT or HCPCS code that were eligible for reimbursement as telehealth services. CMS expanded that list to about 260 and continues to grow that list. And then what CMS had intended to do was out of that list of additional services, they identified most of them as what they called Category 3 services, meaning that they would continue to be covered as telehealth services through the end of 2023. Now what happens? Well, we see that an entire list of services continue with us through the end of 2024, or is CMS going to do some cut and paste to the telehealth rule? The other significant issue is the payment rate for telehealth services. Through the pandemic, CMS has paid for telehealth services at the non-facility rate. Pre-PHE, if you delivered a service fee telehealth and did that in a physician office, if that was the site of service physician office, it was paid at the lower facility rate because CMS said, well, you don't have the same overhead expense if you're doing telehealth, so we're just going to pay you at that lower facility rate. Yeah, right was sort of the reaction from the industry, and so CMS came back very soon after this process started and said, no, we're going to pay at the non-facility rate, and you're just going to use modifier 95 and bill the place of service where you would normally see the patient face-to-face. Now, in the final rule for 2023, CMS said, at day 152 post-PHE, we're going to go back to the old way of doing things where you'll no longer use modifier 95, you'll instead use the place of service, and we're going to go back to paying you at that lower facility rate. So what happens on day 51, 52 now? We don't know how CMS intends to pay for telehealth going forward. We also have the issues of the OIG at the Office of Civil Rights, the Notice of Enforcement Discretion that they published, one with regard to HIPAA waivers for the use of telehealth, the other with regard to the waiver of copays and deductibles. Will those continue post-PHE? What about the use of telehealth to provide direct supervision? Will that continue beyond the end of this year, which is currently scheduled? We also have the outstanding issues of reimbursement for hospital outpatient department and COB Method 1 services. And the other issue, which I think is really problematic because it requires a legislative solution, is the use of telehealth as the in-person medical evaluation prior to ordering a controlled substance. That is actually part of a separate legislation, the Controlled Substances Act. It is not part of the Medicare statute on telehealth. And that Drug Controlled Substance Act says that, yes, the DEA has the authority to permit telehealth visits, but only during a public health emergency. So once the PHE is ended, no longer able to use telehealth for that purpose. We'll see what happens going forward. So that's where things stand on telehealth. It's a good solution. It still needs some work, but again, we will wake up on January 1st, 2025, absent any action, and we'll be back where we were with all of the 5 Section 1834M restrictions on telehealth. There are built into this statute also some requirements to do some studies and evaluation on telehealth, and hopefully we can get to the point of deciding that it is effective and we do want to pay for it going forward.
And Martie, one thing on that, I mean, the studies that are built in really looks at program integrity and that kind of thing. Are things being done appropriately? Are people billing for services that were never provided, et cetera? The other study that I think has got to really have some focus is what beneficiaries think of telehealth, and are they going to be willing to give it up? We see so many people who rather than going to a doctor's appointment, traveling, etc., they are doing things via telehealth. I think when you start to try and take that away from Medicare beneficiary, it might have been easier to take it away last year. Carrying it out to the end of 2024, going to be very difficult to take it away.
You know, when the telehealth extension that's in the CAA 23 was actually a separate bill that had passed the House, and it was some ridiculous, like, 410 to 20, and I think that's a factor of that these, the congressmen were hearing from congresswomen, hearing from their constituents saying, "Don't take my telehealth away," and hopefully that will have the evidence to support it, again, to convince the Congressional Budget Office not to attach some ridiculous price tag to a telehealth extension that makes it unmanageable. So Kathy, with that, let's talk about the rural extenders.
Sure. On the rural side, just to make sure that people are aware of some of the things that were included in the recent legislation, the Medicare Dependent Hospital Program and the Low Volume Hospital Program are going to continue to be paid, but up through the end of federal fiscal year 2024. So we're looking at a September date again, like we've had in the past. So September 30th, 2024 would be the expiration of those programs without any additional congressional action to continue them.
Yeah, Kathy, a lot of the folks we were hearing from that were evaluating this rural emergency hospital option, they were these small PPS hospitals that were facing the loss of their low volume hospital program.
Exactly.
And now with that secured for another 2 years, they may continue in their current model. But again, what do you do when you get to the end of FF?
Are you holding out hope that they continue it longer or make it permanent? So we don't know what's going to happen there. The rural home health add-on payment, this is essentially for those home health services that are provided in low population density areas. It's a 1% add-on to the home health payment. Those will continue, as well as the rural ground ambulance add-on payment. Interesting, just to call your attention to the fact that under the No Surprises Act, there was not a provision impacting ground ambulances other than that there would be a work group formed to evaluate the application of No Surprises Act and balance billing on ground ambulance. The initial meeting for this work group was scheduled for this month and it has been canceled. So going to be interesting to see what actually happens with ground ambulances moving forward, but at least for now, they do get to continue with that 1% add-on. For rural hospitals, there is going to be an increase in residency slots. There will be about 200 new residency slots that will be available beginning in 2026 for distribution. However, 100 of those slots are going to be earmarked for psychiatric or psychiatry or psychiatric subspecialties. So it will be something that it will be interesting to see if these slots are actually picked up. But out of those 200 slots, about 10% would be going to rural hospitals. We will see what happens with the rest of them. There is the CDC Office for Rural Health that has been established under this legislation. And then they are also going to be increasing funding for the a number of rural health grant programs, such as the Flex program. So additional dollars going into those programs moving forward.
Yeah, I mean, the good news was there's just a laundry list of these programs we watch every year to see what's going to happen. And recipients are always watching these grant programs to make sure there's dollars available the following year. The good news is everything kept its dollars. The even better news is several of these programs got additional dollars, especially the opioid response program saw a significant increase. The rural opioid response program saw a really significant increase in its dollars. So there should be new grant opportunities coming down to rural communities. In addition to a lot of these states that have been party to the opioid settlements, most of the states have started receiving their first round of dollars. In Kansas, we just got our first settlement dollars. It's $34 million. And again, most states are looking to push that out as grant dollars to communities. So if you're looking for opportunities, figuring out how you could apply for those dollars and use them to really enhance your substance use disorder programs as well as your overall behavioral health programs.
Medicaid is going to be a slightly different story. Medicaid and CHIP, I think you are familiar with the fact that when the public health emergency began, there was an automatic increase in the federal medical assistance program funding that is a match program to the states. Each state has its own dollar amount that is matched or a matching percentage, but they increased the match. Beginning with the public health emergency. They are now going to be slowly, but not that slow, reducing that match. So essentially where we are currently at a 6.2 match does not matter when the public health emergency ends, but as of April 1st, they will be reducing on the Medicaid side, they will be reducing that 6.2 match down to 5%. By the end of the year, it will be at 1.5%. You can see on the slide that we're also seeing the same change in the match rate for the children's program as well, the CHIP program. So recognize less money going to the states for this expanded population under Medicaid. The requirement for continuous coverage is also going to end at the end of March this year. And therefore, states are going to have to move forward with evaluating those patients who have been, or those individuals who've been added to the Medicaid coverage, and to make sure that they do meet the requirements for continuing to be covered under the Medicaid program. If they are not covered, we are going to be dealing with a lot more uninsured patients, that taking us back, I would say probably worse than we were pre-public health emergency in terms of the number of uninsured. It's estimated that about 19 million individuals would become uninsured through this renewal process and would not be eligible for additional coverage anywhere else. So recognize that as this FMAP goes down, and as the states are doing their renewal process, you're going to have a number of individuals who might have Medicaid coverage today, but they will not have Medicaid coverage after March.
Yeah, and it's going to be, I mean, the impact can be really broad. You know, let me take an example. Beginning of the pandemic, person loses their job, has 2 kids, they go on Medicaid. Person then secures a job, rather than buying family coverage through their new employer, they buy individual coverage and they've kept the kids on Medicaid. That, when you do the renewal process, those 2 kids are no longer going to qualify, they're going to go off, but they'll most likely go on to their parents' insurance at that point in time. So in that case, you don't have an increase in the number of uninsureds, but that is probably the exception, not the rule. Granted, we also have expansion of marketplace subsidies, which should also help, again, provide coverage for a number of individuals. But even these think tanks, which I don't know where they get their data or how they do the magic math, but these think tanks say that we're most likely seeing, 19 million people flood back into the uninsured market. And certainly you can all appreciate how that impacts healthcare providers going forward.
Well, and you think about it, whether it be through the exchange or that individual who can now add the wife and children onto the employer plan, it's paying for it becomes the issue, and having the dollars in today's economy to be able to actually cover those costs.
Exactly. And the other thing is, if you have any reason to call your state Medicaid agency, don't be surprised if they don't answer, because this process of going through a renewal is just incredibly time consuming, effort consuming, and the like. But they have to literally go through every single person on the Medicaid rolls and confirm eligibility. The good news for those individuals is that there are a number of protections built in. So you don't end up losing your Medicaid eligibility because you didn't receive the letter that was asking you to confirm your income. So there are protections built in for that process.
But you do need to be very careful with those patients who you are seeing today who have Medicaid coverage, and to continue to verify that. Don't just assume that it continues for those individuals. There were some other provisions impacting Medicaid that were included in the legislation. They have made permanent the option for state plans to provide 12 months of postpartum coverage. They have also made permanent the requirement. The first one, the postpartum coverage, is an option for the states. The requirement for continuous coverage for children under 19, that is now a permanent requirement on all of the states. And that would be effective in January of 2024. The CHIP program is going to continue for 2 years, continued funding for that. That takes us up through 2029. And then there is an extension of the Medicaid money follows the
person, typo, sorry.
Money follows the money, never mind. But the money follows the person, a demonstration project that will continue. Martie, you had something on the maternal mortality?
Yeah, I just couldn't resist the opportunity to include this on the slide because, I mean, there's a crisis in the United States with maternal mortality, and that's a measure of the number of women who die within a year of giving childbirth that's related to a maternity-related issue. And so this is, I don't know, I can't explain why it's a state plan option to continue coverage for 12 months postpartum, because the issue is you have a child, but you don't receive the appropriate follow-up care, and you develop complications, which unfortunately in way too many cases results in death. And so the intent here was more states will provide that coverage. Women will continue to receive the care they need, and we can see that number going down. The other thing, it's great that they're making permanent the continuous coverage requirement, because what happens all too often is you sort of get on this, as we go back to regular Medicaid operations, you get in this cycle of you get a job, your income goes up, you're no longer qualify, you lose the job, you get a new job, and all the time the children are cycling off and on Medicaid, and again, not getting the regular visits that they need, not receiving the vaccinations they need as a result of that. So hopefully that continuous coverage requirement sort of evens out their access to health care. Access to behavioral health services, as I referenced, Division FF, Title I, includes a piece of legislation that had previously passed the House and then was included in this legislation. And it is a Christmas tree of programs together intended to address access to behavioral health services, and in particular, access to substance use disorder prevention, treatment, and recovery. And it starts with, and a lot of these new provisions, we're going to have to see how the rulemaking plays out this year, beginning with this new Medicare Part B coverage for marriage and family therapists and mental health counselor services. Typically, these services are provided. We've had to kind of work our way through the Incident 2 rules to get them paid, but now we'll be able to provide direct reimbursement, hopefully increasing the access to these services, as well as encouraging expanded entry into these fields. So we have a wider range of behavioral health providers available. Similarly, Congress has adjusted Medicare's partial hospitalization services benefit now to include intensive outpatient mental health services. So partial hospitalization, there's criteria of what qualifies as partial hospitalization for Medicare reimbursement. What has developed up is sort of this one step lower of intensive outpatient mental health services, but there have been questions on reimbursement with it. Now we eliminate that. We will bring in reimbursement for both those types of services.
And Martie, we probably will see something on that in the outpatient proposed rule that comes out this summer.
Right. You'll see a 50% increase in psychotherapy, reimbursement for psychotherapy, crisis services provided in mobile units. And here's one that, Kathy, you worry about, is this change in methodology for inpatient psych.
I have to honestly say that I think the inpatient psych prospective payment system is probably the most complex prospective payment we have, because it is a per day rate that varies based upon how the patient came into your hospital through the emergency department or not, based upon a diagnosis-related group, but a per diem for the diagnosis-related group. And that per diem changes every day. And so it becomes this whole process. The Medicare Payment Advisory Commission has started looking at this as well, and the complexity of the payment methodology. For those of us who like to read regs and look at how they could be changing a program, be prepared, because Martie and I will be doing a webinar someday in the future, but before fiscal year 2025, on what is being proposed for changes for the psych program.
And what you really hope is through the rulemaking process, you don't lose sight of the intent here, which is to ensure that the providers of these services have a predictable, adequate reambrsment rate. And
absolutely.
So that has not been the case.
Really, if you provide inpatient psych services, you need to be monitoring any studies that are being done. I feel very comfortable in saying that for the Medicare Payment Advisory Commission, this will be a large part of their work plan that would begin in September of this year. And you can always either register to listen to their hearings or download the transcripts and see what they're doing. Their slides are also always available.
Or wait for Kathy to tell you what they said, which is what I do personally. In this Title I, there are several new grant programs, renewals of existing grant programs targeted to improve frontline access to care, a significant renewal of the state block grant program, new dollars for those entities that demonstrate that they're qualify as community behavioral health clinics. There is some really interesting new funding opportunities to support primary care practices, including rural health clinics, and their adoption of the integrated care model, sort of that idea of the warm handoff in the clinic from the primary care provider to a behavioral health professional to address behavioral health issues with an appreciation. The primary care provider is busy enough addressing the physical needs of these patients. Can we integrate care in the primary care setting to address those behavioral health issues? Research has been excellent in terms of the efficiency and the effectiveness of these integrated care models. It's really exciting to see these new dollars coming in to help practices establish these programs. That's always been my complaint, is Medicare creates this new reimbursement, and it's a great idea, but they don't appreciate that there are startup costs for practices to launch these programs. And the startup costs are not accounted for in the eventual reimbursement you receive. And this has been the challenge with chronic care management and remote patient monitoring. Yeah, it's a lot of effort to get these programs stood up. There's no startup dollars available for practices to do this. And when you do the spreadsheets trying to prove the program cash flows, there's not adequate reimbursement to cover those startup costs. So this is exciting for me to see that there's going to be these grant opportunities for those practices that want to get into the integrated model. Also, a lot of great new reimbursement available for peer-supported mental health services. Again, research shows, particularly in substance use disorder, peer-supported interventions have been proven very effective, and it's great to see that now the dollars are following those opportunities. Also in Title I, HHS is committed to creating guidance documents and technical assistance to states to support continuum of crisis response services. So this is, the issue of the ER has become the dumping ground for every behavioral health issue. There's nowhere else to go. So the police or family members bring that individual to the ER. And oftentimes, most times, our ERs are poorly equipped to handle these patients. They can't locate an inpatient bed. The idea of these continuum of crisis response services is to help provide those resources to the ERs, either with mobile crisis interventions programs, diversionary programs that are getting these people to the right care. And oftentimes it's not an inpatient bed that they need. What they need is a course of outpatient therapies, being able to integrate them into that activity more quickly. It'll be great to see what HHS comes up with on this, and hopefully this then becomes a launching pad for additional financial support for hospitals and communities that are looking to address these issues. Finally, it would not be an end of the year bill without a new Stark exception, right? So here's your new Stark exception for the year. We are now going to permit hospitals to provide financial assistance or make available financially to physicians participation in evidence-based programs to improve their mental health, increase resiliency, and prevent suicide. And as is the case with Stark exceptions, it's about 2.5 pages of text in the final bill. And the question I just can't avoid is, really, were you going to pursue a Stark violation against a hospital that offered these things to their medical staff? Was it really? Sorry, it's just really, if you're going to tell me I violated the Stark law and have to repay millions of dollars in Medicare reimbursement because I offered my physicians resiliency training without charging them for it. But okay, enough of the indignation in this. It is important to appreciate here's yet another opportunity for hospitals without fear of fraud and abuse violations offering support services for their medical staff in these challenging times. Did that sound okay, Kathy?
A little snide, but you're all right.
Okay, good. Can't avoid it. Can't avoid it. It's the old lawyer in me coming out every once in a while. Other provisions. So this is sort of the potpourri of everything else in that, thousands of pages of long of legislation. Kathy, I'll let you take the first one. Yep.
Okay, so a couple of items that I'll cover, and then I'll make a comment on one as well. under the other provisions that were included, one that will be coming to a hospital near you soon is a separate payment. Let's make the outpatient prospective payment system a little bit more complex, because now there will be a separate payment for non-opioid pain treatment, currently packaged with the ambulatory payment classification group, the APC, for surgical services. They are now going to give you a separate payment for that pain treatment, and that will run for a 3-year period from 2025 through 2027. However, they will cap the payment for that pain treatment at 18% of the ops rate for when those services are, when the pain treatment is not used. Okay, so recognize that there's a limitation on the payment that you will receive. It's a 3-year period. It doesn't start until 2025. And I picture modifiers. I picture more coding on claims, because you're going to have to identify this pain treatment, the non-opioid pain treatment, some way or other on the claim, and then there will be a limitation on the amount that they will pay you. Fun reading the regs for that will be proposed for 2025.
Okay, Kat, this makes perfect sense, right? I mean, if you can make the case that for some individuals, having surgery and the pain relief associated with that becomes a gateway to substance use disorder, why is this only OPPS? Why isn't also the ambulatory surgery centers?
Well, what tends to happen is and it could be proposed for the ASCs, because remember, they are paid under a modified OPPS. So it could very easily be adopted there. I think they could get away with it. But it really will be a way to provide pain management for patients without using opioids, and to see how that works. I think it's a good step, but complexity in your billing and reimbursement side. Another one that is out there, I have some people who are probably listening in. One of my favorite lab folks who is probably saying, they're never going to do this. They're never going to do this. But the CLIA requirements related to the supposedly required hospital reporting of payer data and what your commercial payers are paying you for lab tests that are covered under the clinical lab fee schedule. That reporting has been delayed another year. The reporting has been delayed, as has any reductions that would come in reimbursement that would have come about as a result of that reporting requirements. My understanding from folks at CMS, they would like to see this go away. They can't make it go away. It's legislation. And therefore, there literally has to be either legislation that says this is no longer a requirement, period, or we just keep getting a 1-year delay and a 1-year delay and a 1-year delay. But we got another 1-year delay. And Martie, I'm going to let you do hospital at home, but I would just like to make a comment about it, just like with telehealth. As beneficiaries start adopting and using hospital at home, it's going to be hard to take it away.
Exactly. So this is the program that it's a waiver of the 24-hour nursing requirement, excuse me. And it allowed hospitals to, a patient that either came in through the ER or was an inpatient admission, completing the DRG stay in their home. And there was a program that's been, it's a waiver you have to apply for and be approved for. The program has been stood up, the Acute Hospital Care at Home program. Somewhere in the neighborhood of 300 hospitals, I think, have now been approved for it. The volumes have not been really high in terms of the claims submitted, but I think that's just been the learning curve. And so the good news is the ZAA 23 is extending that learning curve. So we'll have through the end of 24. If your hospital has contemplated this program, but sort of was thinking, well, it's going to go away, so why should we make the effort now? Here's your chance. To get into the program. It's actually has a really impressive sort of learning lab characteristic to it. The hospitals we've been working with that have participated in this. So there's a lot of sharing of ideas and technology ideas and staffing and all of that. So as Kathy said, it makes sense in the future. I think we have a good old HCRR recording from, was it last year we did Hospital at Home?
Mm-hmm.
And we talked about this program in detail and sort of the opportunities in the future. So if it's something of interest, you can always go to the PYA website, look under Insights, and you'll see the entire list of 41, now to be 42, HCRR webinars, and find the one on Hospital at Home. Here's one of those provisions that you wish they still had hearings so that you knew what legislative intent was. There's a provision that requires Health Resource Services Administration, HRSA, to provide a congressional briefing on the actions taken thus far to safeguard 340B covered entities' lawful access to discounted drugs. What I think this means is this announcement by a number of companies, drug companies, that they are going to discontinue participation in 340B, and Congress is looking for its options of what it can do. So there could be a battle brewing here. The 340B program is sort of from both sides, right? It's like, well, we're going to reduce your reimbursement here, and the drug companies are going to get you here. And I think we're going to be fighting this on two fronts and hopefully making ground both ways for the hospitals that rely on 340B. As referenced previously, there are numerous provisions in Title II of this bill, of Division FF, which address the response to pandemics. It is primarily organizational changes, not really dollars being pushed into these solutions, but hopefully we're just as an organization, the federal government is better prepared to address the issues coming forward. More other provisions, Kathy?
Yes, the annual cap on payments for nursing and allied health programs, that has been addressed and has been eliminated, as well as we mentioned this already, the 200 new GME slots, 10% of them going to rural hospitals, but then you can see the other measures for the allocation of those slots. Recognize again that half of these 200 slots are going to go for those who are practicing or will be practicing in psychiatry or psychiatric subspecialties. So if you have a program in that, you have an opportunity for some additional slots. Rural hospitals then are, where I show the 10% of the slots are allocated for, recognize this is kind of in order. Okay, we start with rural hospitals and then we work our way down. So it is an opportunity. We do need more slots than these 200, but hopefully we will get them eventually. And then the last slide, Marty, y'all are going to get to hear from us again on February 8th. And on February 8th, it's going to be so many rules, so little time. And you're going to, we're going to address some of the changes that are being proposed related to Medicare Advantage. And that would include the revised definition for overpayments. Talk a little bit about prior authorization under the Advancing Interoperability Rule.
A little bit. Let's talk about it a lot. Okay, sorry.
Okay, the requirements for a new transaction standard related to attachments and electronic signatures, kind of thinking about how that might tie into the No Surprises Act and the ultimate requirement to provide information and waiver information and like that to the payers. We've got non-compete on the part of the FTC. Does this apply to for-profits or not? Does this apply to not-for-profit hospitals or not? That's an issue up for discussion. The conscience provisions that are out there, and then also the confidentiality of substance abuse disorder patients. So a lot on the horizon, and maybe even a little bit more on No Surprises by February 8th.
Say it isn't so. Kathy, gold star to us. We actually completed our content within the 1 hour allotted period. I hope this was helpful in understanding the CAA 2.3. Certainly, we did not cover every provision potentially relevant to healthcare providers here, but provided an overview, and certainly hope you appreciate that what's going on in Washington is directly impacting us, and we just can't keep our eyes off the prize. So thanks so much. Laura, back to you.
Thank you, and thanks to our presenters, Martie Ross and Kathy Reep. If you have any questions, their presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.